Yes.
So, good evening, everybody. I hope everybody is well. Hope that everybody that you love is well, and I am praying along with much of the rest of the Jewish world for your recovery, but even more than that, for moving on to an era of peace and progress in the Middle East. I think you Israelis are just an amazing, resilient people. I'm sorry for the pain that you went through, but here I am trying to add some small measure of progress to you through helping your children grow healthy. I know that a lot has been said about what modern children are going through in a time even of prosperity where the things that we think are so wonderful about modern culture, and frankly they are, unlimited food and shelter and clothing and access and now information and community, that these are all good things, but there are some unintended consequences to it. I went over that in the first session. Those unintended consequences are often affecting the way our bodies are growing simply because our bodies weren't really designed to be in this modern environment. One of the major changes is the way our faces are growing. The bones on our face are just not expressing themselves quite as well as they used to. And when I say used to, even just in the past 500, 600 years, there's been a major inflection point in the way that our jaws are developing. So there has been some work over the past 100 years in helping faces grow better. Um, I don't know if you're aware of the name John Mew. John is a orthodontist in England. We just lost him a week ago. May his memory be a blessing, and may he be a winner of the Nobel Peace Prize someday for for therapeutics, because he was one of the stalwart champions of helping faces grow the way that they're supposed to. And that is the maxilla, the upper jaw, has to grow broad and wide and forward in the face. And that's one of the unintended consequences of letting the mouth hang open, of breathing through the mouth because of nasal congestion and so forth, that you can actually reverse some of these consequences by helping the jaws grow properly, through the early years. One of John Mew's students, Chris Farrell, had treated thousands of bioblock cases according to John's techniques, but felt that there had to be a little bit easier way. BioBlock tends to take a lot of time and effort on both the orthodontist, the parents, and the patients. It's not so easy to do. So some 40 years ago, he developed the Myobrace as a way of doing the same thing. Now, different people have different opinions about this, and I've attended um, webinars where we had John's son and the clinical head of Myobrace go head to head about what technique was best, and and both techniques showed wonderful examples. Of course, when you're trying to win an argument, you always show your best work, right? But still, in all, one of the things. Uh, if your microphone is on, and it looks like there's only one of us, yeah, thank you. When uh, when you're helping the faces grow forward, using the Myobrace happens to be a little bit easier way of doing this work. It's a little easier to apply. It is a little easier for the kids to wear. And even if you don't get everything that you wish for, at least you're moving the face in the right direction. And I say that because as a specialist in orthodontics for years, I know that putting braces on tends to move the teeth in the wrong direction. That is, when you're uncrowding teeth or you're trying to get the upper and lower jaws to match or help the jaws grow. There are some techniques that we use in orthodontics, but mostly we tend to adapt the teeth to the shape of the jaws, which makes for straight teeth and what we might call a pretty smile. But in a way, as we look a little more closely at the shape of the face, we realize that braces don't really help this issue much at all. In fact, orthodontists have tended to distance themselves from this kind of growth guidance, saying that it doesn't work or that it's not necessary, or the problems that we see when we don't help the jaws grow, that they're not caused by braces. And that happens to be true. Braces don't cause sleep problems. They don't cause muscle function problems. They don't cause profile problems, but they do ignore all those problems. And so many times they are perpetuating, orthodontic treatment is perpetuating these problems with the face, the airway, the jaws, and so forth. So the reason I stand behind Myobrace is that it at least moves in the right direction with a significant contribution and a great way of applying this in any dental practice. It doesn't necessarily require to be an orthodontist. There are some hand skills that you'll want to learn, but mostly it's that learning between the ears that's important. And that is to understand that malocclusion, that crooked teeth, are not just a genetic problem. They are an acquired problem through this process of epigenetics, which is talking about how our system, our biology, is adapting to this new environment. And once you understand that, then whatever level of dental practice, maybe even medical practice that you're in, there's certain principles behind using the Myobrace that are widely applicable and are that are really necessary. My prediction is Myobrace or any of the number of appliances like it, there are probably another dozen out there on the market, that someday, and maybe someday soon, they will be available in the pharmacies and grocery stores next to the toothbrushes, because people will understand that addressing proper habits, proper breathing, proper sleep for children is just as important as keeping the teeth clean. So with that being said, I'm going to start showing some of the videos now. This is our third presentation. So I will try to accommodate some of the people who may not have seen the first two. They are being recorded. We're going to be talking about some of the nuances today of using Myobrace. I put this up just for those who are not familiar with it at all, that the Myobrace appliance is simply a mouthpiece that looks like a sports guard. It is built with certain features to it that make it a little more sophisticated than a plain mouth guard or sports guard. And they are made for different stages of growth and development. But mostly the intention is to help the jaws grow in a proper way, to help train good muscle function so that good growth can go on, and to train good breathing, and that's both day and night. And so this very simple looking piece really is fairly sophisticated in what it can do. So I started talking about this last time, about the many things that I do with the Myobrace in my practice. And I want to go over this first one a little bit, but how about I just do a brief summary of this slide again, that I use it for as a trial diagnostic, meaning something that we can do for children that not only helps them, but also helps us understand what their problem is. So I want to look at that a little bit more. We use it for breathing training. That is, we're trying to get kids to breathe through their nose, powered by their diaphragm, not by their shoulders, at a proper minute volume in order to provide our bodies with the optimal amount of oxygen, not only to get into our blood, but that can be delivered to our cells. Many times kids are over breathing and they disturb that unique balance between oxygen and carbon dioxide, where carbon dioxide helps control blood pH and therefore helps deliver oxygen. I use the Myobrace for myofunctional repatterning, which means that the muscular efforts of the mouth should be in balance with the way they grow. That is, for specific things that we tried to teach with the Myobrace. One is to breathe through the nose so that you can keep your lips together. That's number 2. So that number 3, you can keep your tongue resting on the roof of your mouth. And the reason the tongue is important to rest on the roof of the mouth is that that is nature's palate expander. The tongue, the posture of the tongue at rest, mind you, not even just swallowing, but at rest, should be on the palate because it stimulates the bone to grow in a certain shape. Without the tongue on the roof of the mouth, that shape, the bone still grows, but the shape changes, and that frankly is what leads to crooked teeth more often than not. There are other therapies that I use to help me with these goals. Sometimes the Myobrace is not enough by itself, but I went through that whole range of different therapies that I can use that are compatible with either using Myobrace during the therapy or before the therapy or after the therapy, to teach those habits. And then we talked about how Myobrace can be used as a retention device. On the right side of the screen, that structure, function, behavior triad is the broader scope of what orthodontics should be doing. So that is not just straightening teeth, but actually helping the jaws grow well, increasing the size and patency of the airway so that children can breathe without effort, making sure that the temporomandibular jaws are not undergoing any specific stress during the time that they're growing, and that the tongue is not an impediment to growth by not being able to get up on the roof of the mouth because of a tongue tie. The function part is not necessarily in dentistry itself, but collaboratively working with professionals that will help reduce inflammation and swelling and stress and some of the other neurocognitive and physical problems that many of our children are facing, again, because of the change in the modern environment. And then underpinning everything is the habits that that really are the cause of the structure and function problems. They are the things that we do, either as individuals or even as a society, in the way we handle this new environment. But teaching kids how to breathe properly, swallow properly, sleep, getting good sleep, get good nutrition, and carry their bodies properly against oxygen. These are all things that we teach our kids, sometimes naturally. As parents, we want them to get good sleep and eat healthy food and stand up straight. But the breathing and the swallowing piece is kind of not really been focused on much. Certainly pediatricians don't really focus on it to any great extent. But now in dentistry, we have the opportunity to look at these things. So the Discovery program fits into this broad spectrum of treatments that I went over last time, and many of them require the use of the Myobrace or use the Myobrace to their advantage. But sometimes it's hard to decide where a patient's treatment should be, what treatment to use. And I have felt since I got into this that of all the different treatments, we should take advantage of the one that's best for the patient. In other words, we have to fit the treatment to the patient, not necessarily just the patient to the treatment. Like, not everybody needs a Myobrace, but not everybody needs an expander. And there are different ways of getting expansion and so forth. So how do we figure out where a child goes here? And that is, we tried to not only get good diagnostic information from the beginning, but we also try to see just how their behaviors are affecting what their outcome, how their function is affecting the outcome, and then we can better choose. So this Discovery program looks at these elements on the left-hand side, and I want to go through them a little bit. Each one requires a little bit of study in a way, but they're not difficult. This is not a skill-based or a hand skill-based protocol. This is more of a diagnostic protocol that all of us are trained in. We just have to know what to look for. So basically, it looks like this. If I go through these elements and we spend maybe 3 months doing this, if the patient shows some improvement in their physical ability and their behavior and the way they can cooperate and so forth, then I can go on to a more biologic treatment, more to the left side of that scale. But if they stumble, if they struggle, if they refuse, whatever it is that's getting in their way from compliance, then I have to take on a treatment that requires less of their participation and more of my participation. This is where orthodontics, in a way, has helped, in the sense that we have spent many decades trying to find gadgets and gizmos and protocols that don't require cooperation, so that the treatment is more predictable and more controllable and better outcomes without having to need cooperation on the parents or patient's part. But of course, the big problem there, as I mentioned earlier, is that orthodontic treatment doesn't always adequately take care of the problems. And so then you get more struggle because breathing and sleep don't, and jaw problems, they don't necessarily get solved. So we have to bring other people into the treatment protocols. So one of the things that I've been doing in this discovery program is using measurement of sleep as a way of determining just how much distress a child is in. Why is that? Well, if you're not breathing well during the day, you're going to have even more trouble breathing at night, because at nighttime, when our bodies are lying down, when they're relaxed, when the muscles go limp, as they do during REM sleep, that we have more trouble breathing at night than we do during the day. But it is my contention that if you're breathing well during the day, then you have a much better chance of breathing well at night. And so, but night is a good time to measure. And because all we have to do is have them wear a device to bed. Now, you may be familiar with what physicians will do for sleep apnea. Of course, that their gold standard is to have children in a sleep lab where they can measure some 14 or 16 different parameters. And there are some home-based sleep tests that maybe measure 5 or 6 or 7, but they tend to be a little complicated. And frankly, for the most part, they're looking for sleep apnea, that is, either the stoppage of sleep or the loss of oxygen during sleep. And that's not the only problem that kids have trying to sleep. Many children can compensate well enough that they don't lose oxygen and they don't stop breathing. But because their bodies are struggling to breathe well, they're also struggling to get a good night's sleep. So the use of this particular device, which is called the sleep image ring, and it's not the only one out there, and I think it will not be the last, because it may not even be the most ideal, but it is easily applicable. The kids can wear it on their finger. Here in the States, we have a physicians group that administers it. And on the bottom left-hand side of the screen, it's a little small, but you can see the spectrogram, the chart that's created watching sleep. It basically compares your breathing rate and your heart rate under the assumption that if you're sleeping peacefully, your heart rate will be at rest. Your breathing will be calm and easy. And we call that stable sleep. But if either of those two parameters should change, if the heart rate should start to race, or if breathing is hampered in any way, whether it goes faster or slower, that's unstable sleep. And comparing the ratio of stable sleep to unstable sleep, you can get a fairly good idea of how well a child is doing during the night. The instrument also does measure blood oxygen, so you can see dips in that. It measures actigraphy, meaning how restless they are, how much they have to move around. It records snoring, so you can hear some of the sleep noises. So the way I do this is that I have them wear it for about 3 or 4 nights to get some good data, not one night of sleep. will tell you everything. You know, we all have good nights and bad nights and so forth. So we look for about 3 nights of data on that. And then I spend the next, say, 20 or 25 days administering certain palliative protocols, the Myobrace being one that I use almost always. And that is, we have them wear it for up to an hour a day, where they get to keep their lips together and their tongue on the roof of the mouth and slowly accommodate to breathing through their nose. We teach them how to blow their nose, how to wash their nose with saline. We teach them exercises to reduce the fluid buildup and swelling in the nose. Teach them how to use their diaphragm. Teach them some good sleep habits, like going to bed at a regular time, having a dark and cooler room, and so forth. And that during those 20 days, we see how well the child picks up on it, how willing they are to do it, how capable their parents are of managing these instructions. And then we retest again and see if there was any improvement. Now, sleep problems may not go away in 3 weeks. They're often habits that have been there for 4 years or 7 years or 12 years. I mean, we think of these kids as very young, but that's a lot of years to be struggling. And to expect it to go away in a couple of weeks is like saying, I'm gonna lose 100 pounds in 3 weeks, or I'm going to get a 6-pack on my abs in 3 weeks. You know, the body just doesn't change that fast. But if we see some progress, then we have a good idea of where to go next. And this is one of the things that Myobrace is really so good at and so easy to apply for. So there are obstacles to wearing the Myobrace. One of them is just, you know, the being organized, both in the office and at home. So in the office, you want to have a protocol that goes beyond just handing this thing to somebody and say, here, try this. Handing a Myobrace to a child and say, here, try this, is like handing them a jump rope and saying, here, try this. You know, it requires education and guidance and organization. So you have to organize yourself. We'll talk a little bit about that. But at home, the patient has to organize themselves too. The parent has to be able to create a schedule or a discipline of some way that says, now's the time to put on your Myobrace, and you're not going to, you know, well, I mean, you can do other things while you're wearing the Myobrace, but you don't get to do the things you like to do unless you fulfill this responsibility. So, for instance, a lot of kids like playing games, or they like reading, or they like you know, video games, or watching movies, or whatever it is that they can do with this thing in their mouth, their lips closed and so forth. But they only get to do it if they have the Myobrace in and they're wearing it properly. That's for up to 1 hour a day. You don't really need to do more than that for most cases. Just like you don't have to go to the gym for more than an hour a day to get physically fit. But you do have to do that. And you have to be able to wear it to bed at night. And eventually, even though it's not so easy at first, but eventually be able to keep it in all night long. So that's a problem of organization. Now, there's also a problem of motivation, and most people that get involved with Myobrace, the first thing they ask is, how do you get the kids to wear these things? And you have to be able to orient yourself to being the motivation for both the parent and the patient. Now, sometimes I have kids that I have parents that are very motivated, and they understand that they want to help their kids grow up healthy, they'll do anything. But I also have parents that are used to, maybe they had braces themselves and they're used to the way orthodontics is being done, where the parent can just drop the kid off at the office, kid walks in, kid walks out, and then you go on to your next thing. And the parent doesn't really want to have to do anything else. Likewise, I have patients that are very positive about this for lots of reasons. Usually the biggest one is that they don't want to wear braces. And or they may be having some difficulty that they want to overcome. But of course, a lot of kids don't have motivation to do anything else than what they want to do at that moment. Thinking about the future is not really something that children do very easily. So, but giving in to their lack of motivation, whether it's on the parent or the patient, that is neglecting our responsibility to help these kids get better. It would be as if your child didn't like reading and their teacher said, well, we'll find something else for him to do. But kids not liking books is no reason to let them get away without learning how to read. It's a skill that's going to be very important, in their lives. I'm thinking that maybe in the age of AI, maybe even books will go by the wayside. But at least for now, learning to read is important. And likewise, learning to breathe, learning to sleep, learning to grow up healthy, have a good face, plenty of room for the teeth, straight teeth. These are all really good reasons that kids need to do these things. And otherwise, we're going to continue to have a generation of children that are being affected, not just with crooked teeth, mind you, but with all the other chronic ailments that go along with not breathing or sleeping well. And then you have to look at the physical aspects. I'd like to show you how I look at that in a particular case today. But that's looking at what's going on with their structure and is there any limitation to how air flows through the airway, to look at their function and see if there's anything that makes the airflow problem worse. And then looking at behaviors, because if we're using compensations to help us breathe, that's not going to help us grow well. So here are some of the things that I look for as far as obstacles. Will the patient be compliant enough with the Myobrace? What are their obstacles? What can we do to help get past them? Can a child breathe through their nose for at least 2 minutes, or do we have to make some kind of referral? I do a test where I just have a kid sit in front of a camera for 2 minutes, keep their lips together and watch what happens. It's not something you can take for granted. And, maybe 30 seconds they do well, but you start seeing how uncomfortable they are if they're not used to breathing through their nose and if they're breathing through their mouth. We want to make sure that somebody turn their microphone off, please. We got to make sure that the patient and the parent are committed to the time and effort that it's going to take. And some kids have physical limitations. I mean, there's special needs children that might have cerebral palsy or Down syndrome or any number of things. And we have to be able to offer remedial help. If there are occlusal interferences, there are ways for us to eliminate that by using composite tracks on the teeth. These are bonded supports. Sometimes they're called planus tracks or myolae or turbos. They help eliminate occlusal interferences. We look at the shape and size of the maxilla and ask this question, not just, is there enough room for the teeth? Is there enough room for the tongue on the palate to rest up there comfortably? Because frankly, many of our maxillas have collapsed so dramatically that there's not enough room. We have to look at the airway from the tip of the nose to the bottom of the throat and make sure that air can flow through there. There's no obstacles to that. Because, and you know, if a kid cannot breathe through their nose, if their nose is clogged, if their adenoids are huge, it's not going to be easy for them to wear a Myobrace. In some ways, Myobrace can help rectify that situation, because the best way to clear your nose and your airway is to use your nose and airway. Right? There is a phenomenon called nasal disuse syndrome, which is all the things that can happen when you let yourself breathe through your mouth. But it is a struggle. And then we're going to look at tethers as well. So these are some of the problems that we look at, that we uncover by doing the discovery program. And now we start to define for ourselves, what are the things that we need to help the child overcome? Is it not being able to breathe through the nose? Is it not having good muscle control over there, over there chewing and swallowing and drinking and so forth? Is their mouth hyperreactive to anything that might be a threat? Gagging, the gag reflex, I take as a neurologic defense mechanism for protecting the airway. And there are a lot of things that have to be considered there. TMJ problems are, I think, more common than we admit, mostly because the TMJ is a very adaptable joint. It can adjust its growth to the functional demands that are placed on it, but it also has to compensate, just like the rest of our face has to compensate. And by the time you get to a point where the stressors on the jaws are so significant that it becomes clinical, but that doesn't mean that's when it started. Just because there's no click in the jaw joint does not mean that the joint is not under physical stress. So we have to watch out for that. And then all the things that might make it difficult for a child to put the Myobrace on. So I go through those separately. I'm just going to skip over this. So the discovery program ends with this 3-month Myobrace review. And I ask these questions. Is the patient able to wear the Myobrace an hour a day, 7 days a week? Is the Myobrace staying in at night? Is the patient able to keep their nose clean and clear? Do they hold their lips together at least a little bit better than they were? Is the patient able to use their diaphragm? We call that belly breathing, and it's not difficult to see. Parent, does the parent tell us that the kid is sleeping better? When I say carbon dioxide storage, we actually measure that in the end of the breath. And paces are an exercise that we use to help children get used to higher levels of carbon dioxide than they had been used to when they were breathing through their mouth. These are the 5 or 6 measurements that I take, if not at every visit, then every few visits, The indicator line tells me about where the upper incisor is in the face. The upper molar width tells me about the width of the maxilla. Maximum opening is a quick screening for jaw function. Tongue to spot looks at the ability of the tongue to raise up to the palate. Overjet and overbite, of course, you're familiar with. The overjet in particular, that has to be taken into account relative to the indicator line. That is, you can have something that looks like buck teeth, but many times those teeth are actually in the right place. It's just the lower jaw set back too far. Now, after going through this simple exam, then I can start making decisions about what comes next, whether it needs arch development, orthodontics, or orthopedics, what further help they're going to need with sleep, with posture, with nutrition. Do they have to get their tongue released? And are there any other questionnaires? There are a bunch that kind of focus on different issues. So, all right, well, I went through those. So now I can start making decisions about where I'm going to treat these red squares. These are all the things I can do with Myobrace, that can help me out with it. And of course, I want to be able to deal with those underlying things of helping children develop an optimal physiologic airway and breathing pattern, and also help with their myofunctional health. So here's some setup things that I do. I make a folder for the kids. In this folder is their name and password for the online app that Myobrace provides. I think of all the things that Myobrace does, it's not just the Myobrace itself that's helpful. It's all the patient support that they give by virtue of videos and cartoons and information for parents and patients. I think the job they have done for putting together a protocol is really, quite wonderful. I have an instruction sheet in there that tells about what they have to do. We have a rewards program. We'll look at this. We have a health coach that works with them, and then we want them to bring their folder and their Myobrace with them for every visit. So the first thing in the folder is the username and password for the website. The 4 goals of Myobrace. These are the 4 things that we want kids to be able to learn and practice. Having a schedule where the kids write down exactly what time they're going to wear it each day, even if it's a different time each day, it doesn't really matter. But they can even split it into two sections if they want to. And we say, write down also the activity that you're going to do. Or we have different, scorecards, so they can show us just how much they've been wearing them. There are stickers that are available from Myobrace that they can put on their bathroom mirror or on their desk or their bulletin board, or a little. We tell them to put them on index cards, and then they can put them around the house without sticking them to the furniture. There are activities workbooks that are helpful from Myobrace, and they can be very helpful. We have a rewards program that gives kids points for doing things that we want them to do. So there, you can look over the list carefully, but they each session with the health coach, they are given certain exercises to do, and to the degree that they do them well, they can get points. So they wear their Myobrace by, I mean, they would get points for bringing their Myobrace in and their schedule in and wearing it to bed each night and so forth. So then they count up their points. Every time they reach 200 points, they get a $10 gift card. And so during the course of the treatment, they can earn 4 $10 gift cards. And then when they graduate the program, they get a 5th card. So it's $50 that they can earn. And, you know, of course, I added, I don't know, I think I added $30 or so to the treatment fee. So it's really the parents and I sharing this cost. And but to the extent that this is something that can keep a child's mind on doing what they want, little positive reinforcement, since they can't think that far into the future otherwise. So each section has specifics about what they're supposed to do for each lesson. And we make a big deal about it. We take pictures of them when they get their gift cards, post them up. Then when we finally get to the year point, usually, we call it the final exam. It's really not exactly a final exam because there may be things that we're going to be doing, but let's consider it like the final exams that you get in school. It's the final exam for that year. It doesn't mean you don't have to go to school anymore, but you know, for this course, you're done. So we have the kids recite the 4 goals of Myobrace, which they've heard a million times. And then we ask them some questions that we've taught them about what the proper way is to eat and keep their tongue and some of the things that they've learned. Then I do retest those sets of measurements plus some others where I'm looking at what has happened over the course of the treatment. And, you know, of course, I want to see things get better. They don't always get better, or some things get better and other things don't get better. You know, unfortunately, when you're talking about helping kids get better, it's different than helping kids get perfect. In dentistry, we tend to aim for perfect, don't we? But that mechanical mindset works against us when we're trying to change behaviors. When you're trying to change behaviors, you're necessarily going to get a bell curve. So you have to be willing to, you know, to understand that. But then I just reward the kid with points if I think they've done well enough, and I'll give less than that if they don't, so forth. And then I make my recommendations for what comes next. In this case, they did well, so we're going to continue with the Myobrace. I'm going to see them as they get through the rest of the transitional dentition, and we'll see how the teeth come in. So I also do the quality of life exam. These are 10 or 11 different elements that look at what a child is going through, both before and after. And we want to see, so in this case, she had high scores on all of these elements circled in black. And then the yellow is where she was when she finished the treatment. We give certificates of achievement along with their gift cards, and that's my my assistant who learned how to put hats on them. I guess Zoom can do that now. And we give them a certificate if they want to help us out by teaching other kids. I only offer a few of these to the kids that really became good at it, and we let them help some of the younger kids. Myobrace gives lots of support, and I really encourage you to take advantage of it. Myobrace.com is very, very helpful for your patients to learn about what Myobrace is about, and myoresearch.com is helpful for you to learn about what is important with the Myobrace, and take advantage of the educational materials that they have available. There's some books that are helpful. This one by Oscar Quiros is about some of the tips and tricks. You can get that on Amazon. Herman Ramirez was one of the first pediatric, he's actually a pediatric and orthodontist, dual degree. One of the first that I read. He's got some great writing now on the use of the Myobrace. There's some videos that are helpful, and then the videos that Myobrace provides for doing education. So I'm going to stop there. Let's take some time to take some questions. Shlamit, you wanna moderate for me?
So if anyone has a question, so now is the time to ask. Actually, I have one question.
Sure.
In total of children that are coming to your clinic, which percent will you use Myobrace?
So let's talk about the kids that are, say, under 12 years of age.
Okay.
So, and then we start at about 3 or 4 years of age. Actually, we start earlier than that. I use a similar device called a MyoMunchie for the 1-year-olds and 2-year-olds. Myobrace has a similar one called MyoChew. I'll use that for the 3-year-olds. Maybe, the kids that are sensory deficit or overload problems. But maybe at 3 or 4, we start with the junior series and work our way up. I'm going to say that 80%, 90% of my kids will wear the Myobrace either as part of the discovery program, while I'm doing light wire therapy with the AL for the bent wire system, or they'll do it afterwards. Say if I use palate expanders because I need to take a little more control once I open up the palate, once I open up the airway, once I know that the kids are going to be a little more resilient, then I do the Myobrace afterwards. So I tend to use it really for almost every case, because certainly every case has a certain amount of myofunctional deficit. Now, a lot of people come to me referred by their myofunctional therapist, of course, and then I ask the therapist if they think it would be helpful for the child to wear it, maybe at night, to reinforce some of the things that they're learning with the myofunctional therapist. Some therapists don't like it, and then I don't use it, because frankly, myofunctional therapy is every bit as good if the kid will comply and practice and all that. So I balked at that idea, I have to say. When Chris first told me that every kid should wear Myobrace, I thought it was just like a sales gimmick. But when I started to learn that the origin of malocclusion is not genetics, not solely genetics, that it has a lot to do with function, I started to realize that every child needs some functional help. And whether you use the Myobrace or use another technique for it, that's less important than the fact that you actually address it.
Okay, so you are working in a cooperation with speech therapists?
Oh, certainly. I have a myofunctional therapist at my practice. I have a craniosacral therapist at my practice. I have someone that does reflex integration a little bit. Reflex integration often is a little more involved than we'll get into at our office, but at least we screen for it. And I have a list of 150 local practitioners of all sorts: dentists, speech therapists, physical therapists, cranial osteopaths, um, you know, developmental specialists, sleep hygienists. This really often becomes a multidisciplinary treatment.
Okay. Anyone else has a question to Barry? You can ask now. Yes, Adam. Just a second.
Here. Hi.
Hi, Adam.
I'm Adam, and I'm a speech therapist. I'd like to know if the Myobrace can help with asymmetry with the of the jaw or of the lips and cheeks. If you have a
Yeah. Is it physical
yeah,
asymmetry or functional asymmetry?
about a specific kid who's also a nose breather, a mouth breather
Yeah.
most of the day.
Yeah. So asymmetries, there are two kinds. There's the anatomical asymmetry where the bones of the skull are growing unequally side to side.
That's not the case. That's not the case.
Oh,
It's functional.
it's a functional, and the functional asymmetry is where often there's not really a good dissociation between the tongue and the jaws. That
Hmm.
the ability to really use the tongue independently has not been acquired yet. Um, the 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 Myobrace alone, I would say, does not take care of that, but by establishing the four fundamental good habits, which are the nasal breathing, the lip closure, the tongue on the palate, good quiet swallowing without having to use the facial muscles. That's the foundation for teaching good tongue function as far as articulation goes, and swallowing and so forth. So it's a helpful adjunct. It won't make the problem go away by itself, but it is a helpful adjunct. Yeah.
So you think it can help me in my practice?
Yeah, absolutely. You'll have to talk to Shlomit about the policy of selling these to speech and language pathologists and myofunctional therapists. I think that some places they have to be administered by a dentist, but that doesn't stop you from finding a good dentist that will help administer that for you and then working together. So, and I
Okay,
hopefully,
For
thank
speech
you.
therapists,
by the time the year's out, we'll have some good dentists that can do it.
for
And I know
speech,
a couple in Tel Aviv that are
very good.
working with it.
Mhm.
And I will be coming to Israel in November to teach both Myobrace, and I want to tell you about another event that we're having, but let's take one or two more questions and I'll.
Anyone has a question? Okay, so tell about the events and about
So I came last year at the at the request of Hadass Zagi, pediatric dentist in Herzliya. I thought I was going to come and just talk to a handful of doctors like I'm doing this morning. It turned out we had 161 people at the medical center in Tel Aviv. And so it was such a success that I'll be back again this year in November. We're going to hold it at the Shalva Center in Yerushalayim. It is going to be a day-and-a-half event. There'll be a series of lectures, and they're international lecturers, and I have their names up there. And then there'll be a half a day of workshops and demonstrations, so you get to see how some of this works. I'll be talking about Myobrace in that, and then this event, and we get done on Friday.
Sorry, can you repeat yourself, because the internet got lost, so I don't think everyone heard.
Oh, say that again.
That you said that you are going to speak about Myobrace, and then you have colleagues that are going to be in the event also.
Yes. Oh, all right. Yeah. So I think I was pausing because I was getting a phone call here. I have something to move on to, but the event is Thursday, all day Thursday, and Friday we finish at noon, so you can go do shopping for Shabbat, and should be an exciting time. The auditorium there has 350 seats, and we want to fill it up if we can.
Great. So thank you very much, Barry, and we'll see you in November here in Israel. It will be a great.
I look forward to it.
And
anyone and Am Yisrael Chai.
And anyone that wants to buy today, you have מבצע באתר שלנו 1+1, ואם מישהו צריך עזרה, משהו, שאלה, כל מה שאתם צריכים, אתם מוזמנים לפנות אליי, יש לכם את הטלפון שלי. Thank you everyone for joining us. Thank you, Barry. It was a pleasure.
Barry, it was a really pleasure to hear you again.
Hello, Sagit.
Hi.
How are you?
Fine.
I'll look forward to getting a hug when I come in November.
Me too.
All right. Take care, everybody.
Thank you. Bye bye.
כן, שלומית?
כן.
כן, אפשר לשאול, אז מה באמת המדיניות לגבי...
תראה, יש מוצרים שנמכרים לקלינאיות תקשורת, לטיפול בנשימה, לילדים, זה נקרא מיוזה. זה שני מוצרים, שאחד הוא KS1, השני הוא KS2, שמתחילים בהם טיפול, לשים את הלשון במקום הנכון, לסגור את הפה, לסגור את השפתיים, לטפל בנשימה. זה
כולל כאילו אפשור...
זה כמו ה-K1 של מיוברייס, פשוט במיוזה הוא נקרא KS1, וזה הטיפול הראשוני בתפקודי הפה. את הטיפול ההמשכי של הרחבה, שזה רופא שיניים בלבד עושה.
לא, זהו, שאני מדבר על מטופל שבעצם עבר הרחבה, ועכשיו הוא חזר אליי כדי לטפל בנשימה...
אז בהחלט אתה יכול את ה-KS1 של מיוזה, לטפל בשעה ביום, כל הלילה, מתחילים לאט לאט, עושים את התרגילים, כל מוצר...
אז זה המיוזה?
כן, כן. כל מוצר מגיע עם חוברת תרגילים. יש גם מוצרים לממש תרגול. אם אתה רוצה שהמטופל יתרגל, אז יש את המוצר שנקרא TLJ, הוא מתרגל עם הלשון, עם הלסתות, יש המון מוצרים. פשוט צריך לדעת...
איפה אני יכול לראות את כל הדברים האלה, איך הם עובדים?
זהו, יש באתר שלנו של הפצה, אני אשלח לך בוואטסאפ לינקים לאתר של הפצה, איפה שאפשר לראות, והאתר מידע, שאיפה שאפשר לקרוא על המוצרים ולראות מה הם עושים.
יש שם גם סרטונים של איך הדבר הזה עובד, כאילו, ולמה זה עובד?
כן, יש גם את האתר של מיוברייס, עם סרטונים על כל המוצרים, של החברה הבינלאומית. אני אשלח לך את הכל לוואטסאפ, וזהו, יש גם המון קורסים אונליין.
יש אתר שנקרא Myobrace.
כן, שם עושים את הקורסים אונליין.
ושם יש כל מיני קורסים והדרכות אונליין.
בדיוק. אתה נכנס לשם, אתה נרשם, ואתה יכול לעשות...
להדרכות המתקדמות יותר זה בערך $40 לחודש.
כן, יש את ההדרכות חינם, יש הדרכה של... אתה יכול לעשות בחודש את כל ההדרכות, כן? אבל יש לך הדרכה למיוזה, למיוברייס, לפעילויות, לאקטיביטיז שבאות עם המוצרים, כאילו יש הדרכה ל-TMJ, יש המון הדרכות באתר הזה, באתר אונליין. וזהו, אני באמת אשלח לך לוואטסאפ את הכל, כל הלינקים שתוכל להצטרף.
אדם, איפה אתה עובד?
בפתח תקווה.
אוקיי. טלפון?
05